I'm so excited. Mary Alice, now I feel like I know you.
We're best friends now.
Because I was just a guest with you and Dr. A. It's so nice to meet you, and you're virtually joining us. Obviously, I wish you could be here, but technology has given us this great gift. I have a lot of questions, so many questions. A, myself, but B, my community has submitted a ton. And I've been recently trying to bring on like more specialists on the show to really dive into specific topics because I can share my journey as much as I want, but obviously I'm not a professional in the field and I haven't experienced everything, specifically around fertility. I had a very easy journey of getting pregnant. My births were great, all of that stuff. So first and foremost, I would love to just talk a little bit background about you two, talk about SheMD for a quick sec, and then dive into some listener cues. So Mary Alice, your guys' story is great because I feel like you're kind of like me where you see something and you're like, oh, we're just going to do this.
We're just going to go for it. Like, you're just amazing and we're just going to go for it. So Thaïs, Dr. A, and I met on Molly Sims's podcast.
Yeah.
And I had been co-hosting it when her other co-host couldn't be on. And I loved bringing doctors on. It was my parents had gotten sick and I really wanted to kind of deep dive into my own health and prevention. And I wanted to become my own health advocate because I saw so clearly how you need one when you get sick in this, in the medical industry. And so Molly said, well, you're really, really going to want to stay. This badass doctor's coming. And she is kind of the first person that brought these GLP-1 into, her patients and years before anybody else was doing it. And so I thought it was going to be a weight loss topic. And I was like, well, I want to hear about that. Everybody wants to talk about that. But then we soon got down to business and found out that the reason that she had done this, brought GLP-1s, was because she knew so much about PCOS and was was the expert in Polycystic Ovarian Syndrome. We found out that she had breast cancer and she diagnosed herself.
I know, I listened to that episode. It was wild.
It's wild.
Intro episode.
Yeah, it's amazing. And I really fell in love with her because she's just light and goodness. And her story was so incredible that it was a light bulb moment. I had just shut down my fashion line and was trying to figure out what the next step was for me. And I said, this is it. This is my purpose. This is my why. I really want to bring you into every woman's ears and sight and knowledge and make them their own health advocate because I knew that if I was having those thoughts and coming from a privileged life and my parents having the best medical, care in the world, if my sister hadn't been an MP, my dad would have died 50 times. So that's how this began. And literally I said, okay, we're going to create a podcast. We're going to create a TV show. And now we're creating a supplement for PCOS. I mean, it's just been and it's been a year. I mean, it literally.
No, you guys, I feel like it was so fast.
It's insane.
I'm kind of blown away just when I was speaking to you off camera. And Dr. A, I listened to your guys' initial episode of SheMD, which I'll link, which is your podcast, and I'll link it in the show notes. But your story is also remarkable in the sense of, your history of where your family came from and what you experienced, and then coming here and doctors, all these male doctors being like, nope, just because you're a female or what you look like. And I love that you have really formed the ultimate revenge. Like, okay, well, I'm going to be one of the top OBs in LA and treat every possible celebrity under the fucking sun, and you will know my name.
Oh my God. Yes, I've had an amazing journey. And honestly, as Mary Alice was talking, I'm like, you know what? This woman walked into my life. I wouldn't have never done a podcast. I would have never, I always thought about these things, but I never had the time or the knowledge of how to do it. And honestly, when you're a doctor, you're so overwhelmed with your patients.
You're doing some real important stuff.
It was just, and I feel like she came into my life like an angel, and all my dreams that I always talked about. I've talked about PCOS and endometriosis for so many years. And I feel like she just came in and slowly, one by one, all my dreams are coming true because of her. So I'm so grateful. I
love this.
believe in why people are placed, like our paths crossed at the perfect time in my life.
It was incredible. And it is, it's been a journey, but it's just been the best journey.
I even feel like I just had this moment, quite honestly. I was sitting outside. We recorded for your show. Then you had a separate episode. Now we're here. And I was sitting outside, and this is like the sister studio for Dear Media. And within the past hour of me sitting here, I got to know you. Then I saw a friend of mine who was interviewing you. Then I met someone who I had kind of met, but we were talking about doing a podcast swap. We talked for a second. Her guest was someone who I've been meaning to meet for 5 years, and we keep missing each other. And I had this moment of like, I love when the universe does this. Like the universe is universing, and it's just all the connections, and it's impactful and powerful females. So I love that for us. I want to dive right in. And I actually don't know these answers. So this is me asking, but also I know my community really cares. What is PCOS?
Music to my ears. PCOS, or Polycystic Ovarian Syndrome, is a hormonal imbalance condition that affects 15% of women in United States. If you go to Middle East, that number can go to 23%. Wow. So it's a very, very common condition. The literature says that 75% of these patients are not diagnosed. I'm convinced this number is 90%, not 75%. I really think 90% of these patients are not diagnosed. So this is a condition that affects a lot of women, millions and millions, and it's a top cause of infertility on the planet. And basically, it's either an androgen sensitivity issue or an elevation in the androgen levels in our body. So women have certain amount of testosterone and DHEAS that, in our blood, that's very important for us. However, in certain percentage of women, this level is higher, or our bodies are more sensitive to the amount of testosterone that gets secreted. So because of that, we end up having a lot of symptoms like irregular periods and symptoms of elevated testosterone like hair loss, acne, facial hair, body acne, hyperpigmentation, infertility, weight gain, mood disorders. So it affects a lot of symptoms, it affects a lot of our organs. And because these patients don't get diagnosed and their symptoms get dismissed, they end up suffering throughout their life, whether it's obesity, losing hair, having acne scars all over their face, not being able to have children, having multiple miscarriages. And it's truly devastating. And, so my mission in life has been to bring awareness. We just did a podcast, and, the lady was asking me, how come we hear so much PCOS? And it was like music to my ears. I'm like, it's about time.
I feel like it's everywhere. And that was going to kind of be my next question of, was this just kind of discovered, or why is it right now? Or is it just that people are actually being correctly diagnosed? For me, I feel like, and maybe it's just my algorithm, I don't know, but I'm constantly getting these videos of people being like, what I eat in a day as someone with PCOS, or here's how I got pregnant with PCOS, or I'm having friends who are dealing with infertility and they're saying that they're diagnosed with PCOS. Like, why is it? I'm not saying it shouldn't be a hot topic. I love that we're bringing awareness to it, but why is it only now I feel like we're hearing it all the time?
I think there's 6 degrees of separation between anyone with PCOS that you hear about and me. Because I can think of a handful of doctors who've dedicated their lives to PCOS research. The problem is no one ever talked about it, and their symptoms were always dismissed until I feel like a lot of my patients started talking about it.
Yeah.
And as they started talking about it, more and more people, because they have large platforms and they have millions of followers, so people started Googling it. And, I think it's because of these patients, we've had more and more awareness. I've tried to do this for 23 years, but before social media, it was impossible to get anywhere. I mean, I'm in a little tiny office seeing all these PCOS patients. And for a minute there, patients would come and they're like, well, how come you're the only doctor who thinks I have PCOS? Nobody else diagnoses me. How do you answer that? Do you know what I'm saying? When 90% of these patients are going undiagnosed, how do you figure that out? At least now, as people are talking about their symptoms, I have a patient, Candace, who's an amazing influencer. I feel like Candace alone brought so much awareness to PCOS, so much awareness. And I'm so grateful for these patients as people start talking more and more about it, just like endometriosis also. We had Halsey talk about it, Olivia Culpo talk about it, Tiffany Haddish speak about it. So as more and more women start talking about it, then you can Google right now and learn about all this,
Mm-hmm.
you know, and I feel like Ozempic was the tipping point for PCOS
Wait, can we
because
get into why? Is Ozempic helpful for PCOS?
it is. And in
Okay.
2014, I started using these medications for my PCOS
Wow.
patients for weight loss. So none of this is new information, you know. But back then, we didn't have Ozempic. In 2014, it was Trulicity, very similar to Ozempic. And that's what I used to help my PCOS patients lose weight. So for years, my patients have been losing weight on these medications. But because of some of the celebrity patients who were using this and it leaked out, it blew up in this
Mm-hmm.
country. And because, you know, and I did a podcast, I think with Molly Sims, we talked about Ozempic and PCOS, and then people started talking about it. And, you know, I was talking to one of the executives at Weight Watchers, and I was telling her, listen, a lot of the women on your platform have PCOS. I know you're trying to treat them with for their weight loss, but someone needs to diagnose the underlying condition, which is insulin resistance and PCOS. So I feel like there's more awareness coming to these two topics, which is honestly music to my ear. It's been a lifelong passion of mine. And I feel like just in the past couple of years, because of social media and because of a lot of my patients, there's a lot of awareness.
Yeah. I mean, I know we talked about it earlier on your guys' episode, like the downfalls and the pitfalls of social media, but I will say this is a
Exactly.
positive
Yeah,
where
it is.
people, you know, if people are sharing their stories openly and honestly and vulnerably, you can hear even one of my girlfriends just texted me the other day being like, have you heard of DMER? I think it is. I forget the exact terminology. It's like a a symptom of anxiety or doom when the initial letdown of your breastfeeding. And
Oh,
she's
yeah.
like, I have these feelings. I never knew what it was. And then I randomly got served a TikTok about some woman
Yeah.
speaking about it. I'm like, oh, I've heard about it because of my friend. But yeah, I never thought to tell you. Like, it does bring awareness to
Yeah.
things, specifically with PCOS. And I feel you've mentioned a few of the symptoms. I've seen it mainly on social media of people who are either struggling with their fertility or they have weight that they're unable to lose around like their uterus lower belly area or specifically the facial hair. If someone's
And
listening
acne.
and acne, okay. If someone's listening and they've never even heard of PCOS, but they're dealing with some wonky medical stuff, like what would you say the top things to look out for are? And then what would the next step be?
Very good question. So, first of all, Mary Alice, with her help, we're launching a platform that has a PCOS calculator in September.
Oh, cool.
Patients can just go in, answer these questions, and the calculator will tell them whether they have a high likelihood, or they're less likely to have PCOS. So we're making it very simple. It's free. You can go and just figure out if you have PCOS or not. But if until then, if you want to know if you have PCOS or not, usually you need two out of the three following criteria. Number one is irregular periods. These are patients who don't have regular cycles and their periods fluctuate. Some don't even get periods or they get two periods a year. There is a big range of irregular period. Number two is PCOS looking ovaries on ultrasound. Polycystic doesn't mean you have to have cysts on the ovary. I have even yesterday, I had a patient, she's like, oh, I had a cyst when I was younger, so I have polycystic. No. Polycystic ovarian syndrome means you have a lot of follicles, not cysts. These are eggs basically in a sac. We call it sac of pearls. There's a specific look to the ovaries on ultrasound.
Mm-hmm.
And having said that, it still gets dismissed when doctors do an ultrasound. But if someone has told you you have PCOS looking ovaries on ultrasound, then that's the second criteria. But you don't need an ultrasound because the third criteria is elevated testosterone symptoms. So if you have any one, two, three, or all of the following symptoms, then that's the third criteria. It could be acne, it could be facial hair, it could be body hair, it could be body acne, it could be male pattern hair loss, it could be skin tags on the neck and on in your armpits, it could be hyperpigmentation of the skin around the neck and in your armpit. So if you have any of these elevated testosterone symptoms, then you qualify for the third criteria. So if you're listening to this podcast and you have irregular periods and you have acne, that's your diagnosis. If you have irregular periods and you have male pattern hair loss, if you have facial hair, if you have body hair, that's your symptom. PCOS patients tend to have, so that's how we diagnose it.
Okay.
But generally speaking, PCOS patients have mood disorder. They're anxious, they're depressed, they suffer, they're moody people. And if you look at their history, at some point they either had panic attacks or they've seen a therapist or they've been treated for anxiety or they've been treated for depression. So mood disorder is very common.
Can you have, sorry, I'm
Well,
now.
and insulin resistant. Don't forget the weight gain.
Yeah, I was going down the list. Yes.
I'm now curious. Could you have PCOS if you have these mood disorders, but you have regular periods and you don't struggle with your fertility?
No, you still need
You need two of those three
criteria to get the diagnosis.
So say you get the diagnosis. What is the actual then treatment for PCOS?
So
or is there a treatment?
Yes, PCOS patients have insulin resistance, and it's that insulin resistance that can affect a lot of their symptoms. Majority of these patients are insulin resistant, even thin patients. Insulin resistance means that when patients consume carbohydrates and their body breaks it down into glucose, their glucose doesn't get absorbed into the cells to turn into energy. The sugar stays in the blood because the cells are insulin resistant. Insulin helps these receptors open up, grab the sugar, and put it in the cell. And when we're genetically predisposed to insulin resistance, our receptors don't function at an optimum level. So some of the sugar stays in the blood and pushes our insulin up. Insulin is a fat storage hormone. As it goes up, it stimulates our body to clear that sugar and store it as fat. But high insulin also stimulates our ovaries to secrete testosterone. And it is this testosterone, which is a male hormone, that can cause our irregular periods, our acne, facial hair, body hair, male pattern hair loss. So when it comes to PCOS, especially with patients who have insulin resistance and they're overweight, fixing their insulin resistance is key. You can do that two ways. You can start doing that with a healthy diet, low sugar diet, which is very important. I always tell my PCOS patients their body does not process sugar well. Sugar is like poison for them. So they need to be on a low glycemic index diet.
Can I ask one thing about that? I feel like a lot of the videos I see are like high protein for PCOS. Is that correct?
Low sugar, yes.
Okay.
Exercise is very important. When we exercise, we actually make our receptors more sensitive to insulin. So they start opening up, grabbing the sugar, clearing the sugar out of the blood so they lower the insulin. So diet and exercise is very important. The problem is diet and exercise doesn't always work for these poor patients. That's why they get so frustrated. That's why PCOS patients are at risk of eating disorder, because at age 15, they're overweight. They're eating the same thing that other 15-year-old thin girl is eating at school, but they're gaining weight and the friend is not. And out of that frustration, they start having an eating disorder. That's why it's so important to diagnose these teenagers early so they don't go down the wrong path of having an eating disorder. So, so diet and exercise is very important. There's a medication called metformin, which makes us insulin sensitive. I always say it's like putting an oxygen mask on the face of a PCOS patient. And by making our cells more insulin sensitive, it pulls the sugar in, lowers our insulin. As insulin goes down, our weight stabilizes. And as insulin goes down, the ovaries secrete less testosterone and the symptoms start resolving and the ovulation becomes more regular and these patients get pregnant. Metformin has a lot of side effects. It causes nausea, vomiting, diarrhea in a lot of patients. So out of the frustration for all the side effects that a lot of patients experience with metformin, Mary Alice and I hired one of the smartest scientists on the planet, and we actually made a supplement.
She was telling me.
Supplement. It's amazing. I'm not just saying it because I created it. This has been a lifelong passion of mine. But I feel like there's nothing that exists on this planet right now for PCOS that's as good as this powder, because not only this powder will function almost close to the level of metformin, but it's also anti-inflammatory because PCOS patients have gut health issues. They have their inflammatory markers are higher, so it's anti-inflammatory. It suppresses their appetite. It prevents that sugar spike in their body, and it makes them more insulin sensitive. So overall, it'll help with a lot of their symptoms.
We're so excited. It's going to be a
I'm
game
excited for
changer.
you guys.
It
And I
really
know
is.
people are going to ask, so when can they expect this?
September, we're launching.
Okay.
It's called OVII.com.
Okay.
And you can just sign up right now. And she came up with the name, like, in the living room. We're like, what are we going to call it? OV.com. So yeah, this has been her life mission. And I couldn't believe, I think one of the things, and, when she diagnosed Olivia Munn with breast cancer, that's why it blows my mind, the stories every single day that come into her office. These girls who were dismissed, whether it was saving them with breast cancer, saving their life with breast cancer, or PCOS, where some of these poor girls who can't have children, or they've got eating disorders because there's 3 sisters. One of them, I have one sister. There were 4 girls. We all completely could eat everything, and she was overweight throughout all of high school, and she suffered and suffered and suffered. And she's one of, thank God she's met Thaïs, and Thaïs was like, you have PCOS. And it just made her cry, because she's like, oh my God, like,
right.
Nobody ever like took the time. And I think it's so we're just so thankful and excited about OV.
I'm excited as well.
I can honestly say, and my physician assistants who follow me in the room can confirm it, that every single patient, every single day who comes to my office and I diagnose with PCOS, every single one of them uses one word when I diagnose. A lot of them start crying, and every single one says, I feel validated.
100%.
Yeah.
We talked about this, but I've dealt with a slew of medical issues in the past, and there was so much of me having to advocate for myself, to go to battle for myself with these doctors, to say, no, this is not the cause. Like, it's still wrong. There's still something happening. For years, I was dealing with these digestive health issues, and no one was taking me seriously. And finally, after I think 3 years, 2 to 3 years, we found out that I had mercury poisoning. And once we dealt with that, everything shifted. And I remember crying similarly, being like, this is terrifying, because what the hell? Like, you never hear about this. But also, I feel so validated because I'm not crazy. Like, I felt like doctors were making me feel crazy. I also, on that note of advocating for yourself, someone asked, and this is a question I get a lot, what would you recommend as an OBGYN that someone does, even if they have a regular period, a regular cycle, before they try to conceive? Say, I'll use myself for an example. My husband and I knew we wanted to have kids, and we were going to start trying. And so I remember I went to my doctor, Dr. Gubala. She's been on the show before. I love her. And we did this full hormonal panel. But when people ask me, I don't even actually know what the terms are to ask for. She just did it. But we did a full hormonal workup, and that leads to another topic I want to discuss. But if someone came to you saying, I want to start trying to conceive, what steps should they take beforehand?
There are a lot of steps they need to take, actually, which that's a very good question. The first thing, if you tell me you have one thing to check, Mary Alice, what would it be?
Egg count.
Okay, this is what I want to talk about. AMH?
AMH.
Okay.
So 10% of women have endometriosis. Endometriosis destroys your egg count and quality. You better not miss those 10% of patients. So every single woman needs an egg count. Your hormone panel comes next. Okay, so first you need to make sure your patient has eggs. 2, you need to make sure you ask their age, right? Because age makes a difference. If they're older, if they're 35 and older, you tell them they can go try for 6 months. But if they're not pregnant at 6 months, to come back. You don't let them go for a year. Anything before 35, if everything else is well, they can go and try to get pregnant for a year. So you want to check their egg count. You want to do a hormone panel. What is hormone panel? I check a thyroid panel basically free levels of your T3, T4, your TSH, and your thyroid antibodies, because thyroid really affects your fertility. I check prolactin, which is another hormone that can affect your fertility. I do check, because I see a lot of PCOS patients, I check testosterone and DHEAS, which is a different form of testosterone. Pelvic ultrasound. This is the one test that gets dismissed all the time. I personally, in my office, do a pelvic ultrasound on every single person that walks into my office. I'm a very good ultrasonographer. But for offices where the majority of doctors don't do their own ultrasounds, that's fine. Ask your doctor for a pelvic ultrasound. It's a transvaginal ultrasound. You want to make sure the anatomy of your uterus is normal. You want to make sure there's no septum. You want to make sure you don't have any ovarian cysts. You want to make sure there are no tumors on the ovary. You want to make sure there are no fibroids in the lining of the uterus. More importantly, you want to make sure there are no polyps in the lining of the uterus, because if you have a polyp or fibroid in the lining of the uterus, it can block you from getting pregnant. So if you have a septum, you're at risk of either not getting pregnant or losing that pregnancy early. So it's very important. Ask your doctor for a pelvic ultrasound. Go ahead.
Well, just on that note, why aren't we doing pelvic ultrasounds to like every 16-year-old? Because my friend just was struggling with her fertility, miscarrying, had a pelvic ultrasound and found out she had half a uterus. And she's like, how am I 30 years old? And I'm now finding out that I have half a uterus?
But that's why do you think I'm going down my list? What I'm telling you is non-negotiable.
Okay.
If you're trying pregnancy.
So
egg count, hormone panel, pelvic ultrasound. You start taking prenatal vitamins. You make sure your partner is healthy. If you have this old guy who has had fertility issues and he's smoking pot every day and he's in a jacuzzi and a sauna every single day, then you might want to do a semen analysis.
Wait, is that real? A sauna and jacuzzi, those are real?
Anything that increases the temperature around the scrotum can affect the semen. So usually when couples are trying to conceive, I always say, tell your partner not to go in a hot tub or a jacuzzi right around the time of ovulation. So the other thing is, know your ovulation. You don't need to have an OvuKit at home. You don't need to check your temperature. You don't need to do a vaginal secretion check when you're trying to get pregnant. But you kind of have to have an idea. If your cycles, here's the rule of thumb. If your cycles are 28 days, you go back 14 days, that's when you ovulate. So in a 28-day cycle, 28 minus 14, you're ovulating day 14. So day 14 is the peak day for you. You want to have sex day 12, 14, 16. You don't want to have sex every single day because you can lower the sperm count. But you want to make sure you're aware of when you're ovulating.
And you'll be tired.
Sex every day. Yeah. Well, I feel like, I don't know if this is real or not, but ever since I had a kid, now I'm so hyper aware of when I'm ovulating because my symptoms are increased. I don't know if it was like a hormonal shift, but I know to the day when I'm ovulating because I'm very depressed around my ovulation. It's like, I don't feel like Beyonce. I feel like I hate the world and everything around me, but my body changes. Like even the vaginal secretion is like completely different. But
or you might even feel a pain.
Oh, I feel it. Yeah.
And but a lot of people go through it and don't know it.
Yeah.
So going back, let's say your cycles are every 30 days. Then when are you ovulating?
16.
Bravo.
But now with Flow, like there are all of these apps that you can go on.
I wear my Oura ring.
Yeah, the Oura ring.
You don't need those apps, I'm telling you, because some of those apps are not correct, right? If your cycles are 26 days, you're ovulating day 12.
But I do know a lot of people, I think that's like for normal, right? But I know some people who were ovulating around day like 23 and they didn't know that after they were dealing with infertility, saw a fertility specialist, and then they started tracking ovulation, whatever. But I want to go back quickly to the egg count.
Make sure that friend is not PCOS.
I'll text her. Is that a sign of PCOS, irregular ovulation?
Cycles, right? Late ovulation.
Okay, I'll text her.
Irregular ovulation.
She's pregnant now.
Good.
Egg count. So this is how I have my first child. I get this panel done by my OB. She calls me and she's like, hey, your AMH is like really low. So I want to do it again. We do it again. I think, what's it supposed to be if I'm 30?
So hopefully above 2.
Okay, it's 0.07.
Okay.
So she wants me to see a fertility specialist. So this
Wait
is
a
what?
0.7
Sorry,
or
0.7. 0.7.
yes. Thank you. Oh my God. I'm
Yeah,
at
sorry.
0.07 means 0 eggs. Okay.
0.7. It's COVID, peak COVID. So I have a call with this fertility specialist and she is like, you need to do IVF right away. And like really was telling me IVF, you're never going to get pregnant. We hadn't started trying at all. And I was so taken aback. I remember bawling because that's not at all what I envisioned our experience to be. I set up a call with a separate doctor and I was able to see him 2 weeks later. In those 2 weeks, I tell my husband, well, we don't have to pull out anymore because evidently we're going to have to do IVF.
And you got pregnant.
And I got pregnant. So
let me first stop you here.
yeah, I want to talk about AMH.
0.7 is not extremely low. I don't know who told you that. People
Okay.
get pregnant with 0.7 all the time. It is low for a 30-year-old. So if you have an AMH of 0.7 at age 30, in my gut, I would say, does she have endometriosis? Am I missing something in her?
What are
Number
some
one.
other symptoms of endometriosis?
Painful periods.
Painful periods,
Yeah.
bloating with period, recurrent UTIs, painful sex with deep penetration.
No.
So different patients have different symptoms of it. 0.7 is low, but it's not low enough that you would not get pregnant. That's absolutely false information.
Agreed.
Number one.
Because it happened.
Yeah, and then it happened again.
So 0.7, every 0.1 of AMH is 1 follicle.
Okay.
0.7 means 7 follicles that month. You need to ovulate 1 to get pregnant. When your AMH is 1, you have 10 follicles. When your AMH is 2. So if I'm sending you for egg freezing at age 30 and your AMH is 0.7, I will tell my patient you're probably going to be able to freeze 7 eggs. If your AMH is 1, you can probably freeze 10 eggs.
Okay.
If your AMH is 2, you can probably freeze about 20. So if someone is going to freeze eggs with an AMH of 0.7, I tell them you might need to do 2 or 3 cycles of egg freezing to get to 20 because 0.7 means 7 eggs.
Okay, got it. I just feel like, yeah, I was obviously very thrown. And then I've had a lot of people message me being like, the same thing happened to me and AMH.
But
It's
remember,
terrifying.
painful periods, and I'm going to play Dr. Mary Alice that I've learned from Thaïs. I've gone to the medical school of Dr. Thaïs. Painful periods are the most common for endometriosis. And she always says painful periods are not normal.
Oh, mine are horrible.
Then you probably have endometriosis.
No, you have endometriosis. I can diagnose you right now.
Okay.
Yeah.
So, okay, let's dive into endometriosis.
But that explains your low egg count at 30.
So,
does it make sense?
Yeah.
Now, 40% of endometriosis patients under the age of 30 still get pregnant on their own.
Okay.
But the longer you wait, the harder it'll get and the lower your egg count and quality will get. So
tell me if I'm correct, and I know that I am, PCOS patients have a lot of eggs, but poor quality eggs. Endometriosis patients have less eggs, correct? That's why you're saying that.
Correct.
So I just got very lucky twice in a row.
40% of PCOS patients also have endometriosis. So when you have PCOS and endo, you have to do an egg count and see is endo winning or PCOS winning? Where's the egg count? So that's why in the workup, in the world, you start with AMH, you do the hormone panel, you want to make sure you have a normal pelvic ultrasound, you start taking prenatal vitamins every day, and then you're ready to start. How do you start? Before you start, you want to make sure you don't have endometriosis and you don't have PCOS. Because if you have PCOS, we would put you on metformin. And if you have endometriosis, I would give you 6 months to try for pregnancy. And if you're not pregnant, you have to come back. Now, let's say we did all this and you're ready to start. You need to have sex 3 times a week. And if you don't have any other underlying condition, you're not 35 and older, you don't have endometriosis, you don't have PCOS, you have to have sex 3 times a week and you need to give yourself about a year. 50% of couples who have sex 3 times a week will get pregnant in the first 6 months of their of trying. 90% will get pregnant in the first year. 10% don't get pregnant. Majority of those 10% have what, Mary Alice?
PCOS or endometriosis.
And they just haven't been diagnosed.
Yes.
Okay, so let's go into endometriosis. We obviously know that now, I'm learning, low egg count is a symptom, as is painful periods. What are some other ones?
Recurrent UTIs. These are patients who
I check that box.
I keep going to my doctor and I get antibiotics, but my cultures are negative. Bloating with your period, backache, leg pain, chronic pelvic pain, pain with deep penetration. These are patients who have bladder symptoms. They get bladder irritation. They go to the doctor. Their urine culture is negative, but the doctor gives them a prescription for bladder. A lot of these patients end up having GI symptoms, bloating. They get diagnosed with IBS. They end up having colonoscopies early.
I have a colonoscopy every other year, but that's because I have polyps.
Okay.
What about PMDD, like mood swings during?
PMDD is premenstrual dysphoric disorder, is a severe form of PMS. It affects a lot of
I've been talking about it with my psychiatrist a lot because
and we have treatment for it.
Mm-hmm.
There's no reason to torture yourself. It usually happens in the luteal phase, the second part of the menstrual cycle, and it usually improves when your period starts.
Yep.
It can cause sadness, anger, anxiety, depression, food cravings. It can disrupt your sleep. It can disrupt your relationship with other people. It disrupts your work. It's really disruptive to your life.
Yeah, it's really disruptive.
Then you need to treat it. You can start with yoga, meditation, exercise. Birth control pills sometimes help to prevent these fluctuations. In the hormones. But if that doesn't work, we have medications you can take. I love a medication called Serafem. It's similar to Prozac. You only take it 2 weeks out of the month from day 14 to 28 during the luteal phase of your cycle. It's like water on fire.
Okay, endometriosis. Now we know the symptoms and we've diagnosed myself. What is the treatment?
So endometriosis implants in general grow with hormones, with estrogen. Our ovaries are pumping estrogen every single month. So when it comes to suppressing endometriosis, we can start from a low dose birth control pill. It can be a combination estrogen, progesterone, or progesterone only pill. I tend to like anything without estrogen. So I usually do either progesterone only pill, like let's say Slind or Micronor. If that doesn't work, I personally love progesterone IUDs for endometriosis. It works like magic. Someone like yourself, if you're done having kids, I would put you I would give you a Mirena IUD. If you haven't had children, I like Kylena IUD. It's a smaller progesterone IUD. You just put it in there. It works locally. It suppresses endometriosis. There are medications. There are pill forms you can there's a pill called Oralissa. There's another one called Myfembry. Basically, these medications lower our total body's estrogen, so they can have symptoms of hot flashes, mood changes, nausea, and GI symptoms, but they really make patients pain-free after 2 months. I reserve Oralissa and Myfembry for patients who don't necessarily respond to the progesterone birth control pill or the progesterone IUD. Having said all this, the gold standard treatment, I don't care who it is, the best treatment for endometriosis is laparoscopic resection of the endometriosis implants. Basically, we go in laparoscopically and we cut these little implants that cause these nerve pains every month. And there's nothing that works better than surgery. The problem is, if you operate on an endometriosis patient, it's a very technical surgery. So you can give 100 OBGYNs a laparoscope, 40% of them will probably miss endometriosis. And it happens all the time because sometimes it takes me 20 minutes to find these implants. There is a stromal endometriosis that doesn't have the typical look of an endometriosis. These are little tiny, almost like white lines in the pelvis that you can easily dismiss them, easily, unless you're like really looking for them, you're going to not find them. So these are patients, they wake up from surgery and the doctor says, you don't have endometriosis. So imagine living a life of pain and you put yourself through surgery, you wake up and the doctor says you don't have it. I see that all the time. And then I take them back and I resect all of it, and all their path report comes back endometriosis. So going to a specialist is very, very important. The problem with surgery is surgery alone is not going to fix it. It's just like having someone with colon cancer. You go in, you resect their colon cancer. Do you ever tell them, okay, sir, I'll see you in 6 months? No, because he'll come back in 6 months with cancer everywhere. You have to give him chemo. Endometriosis is the same way. You can do laparoscopic surgery and cut all these lesions out, but you still have to suppress it. So what I do when I operate on these patients while they're under anesthesia, I put a progesterone IUD inside the uterus. That way I can freeze the pelvis the way I'm leaving it. And these patients go and live a pain-free life. When they're ready to get pregnant, I pull the IUD out, boom, they get pregnant. 6 weeks postpartum, I put the progesterone IUD back in, and my patients are always pain-free.
And there's nothing, correct me if I'm wrong, there's nothing you can do to increase your egg count. Like, we're all born with a certain amount of eggs, and they're just dropping like flies every period.
They're just dropping like flies, and those men keep the sperm.
Right?
Yeah.
It's crazy.
So, careful with them. If you're 15 years old and you walk into my office for a yeast infection, I'm checking your egg count.
Interesting.
I'm screening for endometriosis.
But what would that change with a 15-year-old?
In a 15-year-old with low egg count, painful period, I'll suppress their endometriosis. Because if you suppress endometriosis, the egg count won't dive down.
Oh, it won't continue to dive down. Oh.
Because the endometriosis is killing your eggs.
Interesting. Okay, that's very interesting.
My whole job on this podcast is to literally, I'm like, well, say that again.
Yeah.
Make that clearer. Dumb it down.
It's like, okay, we don't know the medical talk.
You sit here and listen to this genius all day long. And, we do the same thing. We do at episodes called Ask Dr. A, where we get so many listener questions. A lot of young girls who are kind of scared to ask their OBGYN because the parent's still in the room, or, I don't know. Those are some of my most fun episodes.
I'm sure. I mean, I have 10,000 questions. I want to just ask one more that a lot of people sent in that I haven't experienced because I had vaginal deliveries. But what are your thoughts on a VBAC, which for anyone listening is giving vaginal birth after C-section? I'm assuming that's what it stands for, right?
Yes.
Okay.
Very good. So, anytime you go into labor, you have a 25% chance of getting a C-section. I was one of them, right? So when you have a C-section, with the second pregnancy, you can choose to have a vaginal birth or you can choose to have another C-section. In the world of OBGYN, as an OB, when you have a scar on your skin and you have a scar on the uterus, you might as well use it again and again and have your babies. However, if you want to have more than 3 children, then we don't want to do 4 C-sections and 5 C-sections and 6 C-sections, even though I've done 7 C-sections, 8 C-sections. It's not ideal. So you want to try to have the patient have a vaginal birth after a C-section, which is called a VBAC. VBAC, it's very important. You have to pick the right patients if you want to have a successful VBAC. Why am I saying this? If the reason you had a C-section the first time was because you had a giant baby, you had a 9-pounder that got stuck on your bones, and you were in labor and that head never passed that pubic bone, it's going to happen again and again and again. So you're more likely to fail a VBAC, have another C-section. But if you had a C-section the first time because you had fetal distress or the baby was coming butt first or leg first, we call it breech, then you're more likely to have a successful VBAC. If you want to have a VBAC, ideally, we don't want to induce you. You want to be with an experienced doctor. These patients have to be monitored very carefully. Anytime you have contractions in the area of prior C-section, there is a risk of uterine rupture. The risk of uterine rupture is about less than 1%, as long as the scar was low transverse, not on the skin, but on the uterus. So if you make a vertical incision on the uterus is at a higher risk of rupture. So for patients who've had a vertical incision on their uterus, if they've had a prior myomectomy, if they've, like when we go in to remove fibroids, or if they've had more than 1 C-section, having a VBAC is not a good option because of the high risk of rupture. Okay. But if you've had 1 C-section with a low transverse cut and you want to try for a vaginal birth, be my guest, but you need to be very carefully monitored. I monitor these patients very early. I rupture their bag of water early. I internalized a catheter that will basically give me information about the pressure of the uterus, because on the external monitors, you cannot know how strong the contractions are, and you want to have an idea so you minimize the risk of rupture. I usually force these patients to get an epidural while in labor, because just in case the uterus ruptures, we don't want to be in a panic trying to put a catheter in their back. So if you take precautions, if you pick the right person, VBAC is a great option for patients who really want to try and have a vaginal birth.
Okay. I want to end with, I would love for you to hear my story because I would like some potential validation, and I'm curious what you would do because I have the ears of a top OBGYN. I was pregnant with my second, and my due date was October 21st, and October 6th, I woke up in the middle of the night. I was contracting every 5 minutes. So I was, 37 weeks, 37 and a half. I was contracting every
I'm sorry, is this your first
second.
pregnancy?
Second.
Okay. And your first one went to term?
Yes, I delivered at full term with a partially elective induction. I had been contracting. I had been fully effaced. I was 2 centimeters dilated, and I went in and got induced.
So you augmented, not induced. They basically augmented your labor.
Correct. It was just Pitocin, no balloon, none of the other things. I called the doctor. They're like, come to the hospital. It sounds like you're in labor. I get to the hospital. I'm 4 centimeters dilated. I'm fully effaced. I'm contracting every 6 minutes. I'm in triage, and I'm just not progressing. And they were like, you need to go home. And I was like, what? And they were like, yeah, you're not progressing. What?
Were you in a lot of pain?
Yes. But I have a high pain tolerance, so I wasn't like doubled over crying. So they sent me home. I now am so confused because I feel like I always know my body very well. I'm really thrown for a loop. I'm like, what is happening? A week later, same thing. Overnight, I've now lost my entire mucus plug. Overnight, I'm contracting every 5 minutes.
So can I stop you?
Yeah.
Your mucus plug was lost the first time, because at 4 centimeters, there's no mucus plug.
Yeah, it was lost the first time. I lost part of it in the hospital after their examination.
Okay.
Like I lost the last part of it. I go back. I'm in triage. I'm still 4 centimeters dilated. I'm
You're
not
38 weeks at this point?
What?
You're 38 and a half weeks?
Yes. I'm
Okay.
not in enough pain. And they tell me I need to go home. I'm now bawling because I'm like, no, I can't live like this. Like I'm on and off contracting every day.
Right.
I'm in so much pain. I'm so confused. This baby's also going to fly out of me, I feel like, when it actually happens.
In the car.
No, I was terrified because I wanted that epidural. I'm begging them to induce me, and they say they're full. They talked about potentially bringing me into a separate room and giving me a dose of, I don't even know what, to almost like knock me out.
Yeah.
But they say they're too full to even do that, which I know isn't their fault. And they send me home. Then I wait another week. I have my induction set. I call that night. Hey, I'm just confirming. I'm supposed to come in 2 hours. They told me to call 2 hours before. It's a 7 p.m. induction time. They say, sorry, we're full. I then get in a fight with the OB on call, who's a male, who basically said, in short term, he goes, if I had known when I signed up to do this 30 years ago that I'd be on the phone with people complaining like this, I wouldn't have done it. And I said, sir, what time are you on call till? Because I'm not delivering with you. And he told me the time, and I said, thank you. I will not be coming to the hospital tonight, even if I'm in labor. I called my old OB, who I love so much in New York. I begged her, please, can I drive into the city? Will you just deliver my baby? And she's like, I can't do that. You're not my patient anymore. The next morning, I end up going in. I finally get induced. I end up loving the doctor who's on call. I had actually never met her, but she was amazing. And I pushed for 1 minute and 30 seconds. He flew out of my body. What would you have done?
My case is very different. First of all, I think part of the problem of what happened to you is when you switch from doctor to doctor.
Agreed,
You
but I
know, that would
moved.
never, no, even in the same practice.
Oh, agreed.
If you're my patient, you will never get an on-call doctor. So
Yeah,
I deliver 100% of my patients. I have a relationship with them. I fight for them.
that's
No
my
one
old
tells
OB.
no one tells me the hospital's full. I would have been your advocate because you were not your own advocate
Yeah.
in this case. So, so my situation, my patients are spoiled. I always say, they come, they go, they have the most amazing experience, and they think that's what happens outside. And it doesn't, partly because I have the luxury of not being overwhelmed with as many patients.
Mhm.
I stopped taking insurance. So, but I'm always there for my patients. I've never, in 8,000 deliveries, even when I was taking insurance, I've ever had a story like yours, ever. But I've never had a partner. And when people don't know you, there's a disconnect.
Completely.
Right. So when you build a relationship with your doctor over 10 months, they love you. I love my patients as much as they love me. So it's a two-way street. They're my family. If they're in pain, I will do everything in my power. Even if there's no room, I would admit them to the hospital and manage their pain, but I would never say, just go home. I
Okay,
would
thank you.
never do that. So, but that's another thing, right? Being a woman, having a male doctor. I mean, there are amazing doctors out there that are male, but it's hard. Like this is not just pregnancy; it happens all the time. Women's symptoms get dismissed. He probably thought your pain is not that bad, and you're
No.
just exaggerating, and you can just go home. I could not even tolerate a contraction past 2 centimeters. Even the midwife was telling me these are not real contractions, and I was screaming in pain. People have different pain thresholds. You can't tell
Yeah.
someone, you can't dismiss someone's pain, and walking around at 38 and a half weeks at 4 centimeters completely, if a second baby, I would absolutely keep you in the
Thank
hospital.
you so much because
I
I
want to have another baby so Dr. A can deliver my
I'm
baby.
literally like might fly to LA. No,
But
I thought I
feel
was going insane.
I feel that the on-call doctor's pain because it's like you get beaten up. It's not that poor doctor's fault. It's the
Right.
hospital institution. There have a lot of patients. They don't have
It's the
enough room.
system.
It
It's
is.
the system, and the doctors burn out.
Of
So it's not
course.
always our fault. I have patients who stay behind doors, but all I'm saying is when you stay with a doctor for a long period of time, they are your advocate
Hmm.
and they fight for you. We're all fighting for that one bed. And, I had Cedar Sinai wrote me up why I call every time I have a patient and I pick room 2 for delivery because it's the nicest room and it has the Hollywood sign and it has the most beautiful view. And I replied back to them, I'm like, well, nobody else is asking for room 2, so why do you care?
Right.
And they're like, well, that room 2 should go to all patients, not just your patients. I'm like, I understand, but I don't see other doctors advocating for the room. They don't care. I care, so just give it to me if I care so
Well,
much.
now you done it. Now everybody's going to ask
Yeah,
for
is
room
that the
2.
Beyonce room?
You've done it
Isn't
now.
there like a Beyonce suite or something? Or is that in New York, maybe? I don't know. I will say I gave birth at the new Alexandra Cohen Hospital with my first, and it was like a Four Seasons freaking hotel. That thing is a nice. My second, not so much, but that's the Jersey experience versus New York. Thank you guys so much for coming on here.
This was so
This
fun.
was so fun, but also so educational. I'm leaving with a lot of information. Where can people get more of you? Where can they support you?
The podcast is on everywhere where you get your podcast. It's SheMD, and you can go to our site, shemdpodcast.com. We have a breast cancer calculator, risk calculator, which Dr. A wants every woman to take.
I will go do that.
There's other tools that we have on there that we feel every woman should have. Our product OV is launching in September. It's ovii.com. So sign up, put your email in, and we'll let you know when it's out.
Perfect. And then what are your guys' individual handles?
I am Haney Official, at Haney Official. And what are you, Thaïs?
draliabadi.com.
Okay.
Is my website.
It'll all be in the show notes. Well,
Yeah,
thank you guys
perfect.
so much.
Oh, this was so much fun.
So great.